Assalamu alaikum. Good morning, everybody. Thank you for inviting me to this great conference. I would present this case, which has been done by one of our colleagues in King Saud Medical City, but I was lucky to help him with this patient. So our patient is a 63 years old male patient who is known to have hypertension and ex-smoker, admitted with non-STEMI and found to have cerebral disease. He kept on optimal medical therapy, including aspirin, ticagrelor, bisoprolol, brindapir, rosuvastatin, and pantoprazole. Baseline ECG showed non-significant STT changes, sinus rhythm, and the baseline blood investigation was within normal limit, except troponin and a little bit increase of LDL. Echocardiography showing impaired LV function with multiple regional wall abnormality, and distal apex was dyskinetic. So we did a cardiac MRI, which returned back with non-viable apex, but the anterior LAD or anterior wall is probably viable. That's why we discussed this patient in heart team meeting, and the decision was to go for multivessel PCI. So the PCI was uneventful, and the RCA PCI was done successfully with the 3.0 stent, optimized with 325 NC balloon. Then LAD stented up to the ostium of the LAD. And the operator decided here to hit only the ostium, not to cover the distal left vein. When he went to the distal circ, he tried to prepare the lesion. It was suboptimal preparation. Then when he crossed the stent, there was difficulty to cross the stent distally, and he decided to take it again out, then to cross again with NC balloon, but unfortunately the stent was stuck to the distal left main, and part of it was dislodged in the aorta. So he tried to pull everything out. Unfortunately, the wire is out, balloon is out, but the stent was hanging in the left main, aorta, and ostial LAD. So urgent heart team meeting was made on table, and the decision was to go for the first retrieval with backup ECMO, but it failed, then to refer this patient to surgery. We discussed the option of retrieval, and because the wire is lost from the coronary, and there is a free end of the stent, so we thought the snaring would be the best option for this patient. As mentioned by my colleague, Dr. Sami, he reviewed the techniques for retrieval of the stenting. We thought the proximal grasp technique is the best because we have free end floating in the aorta of the stent. So we upgrade the radial sheath. We took a 7 French sheath. Then we go with ABU 3.5 guiding catheter. As you see, we touch the tip of the stent. Then we use a gauze neck snare. We manage to catch the tip of the stent. Then we pull everything out. Because the tip of the stent was stuck to the ostial LAD stent, so everything went out. The damaged stent and the deployed stent also on the LAD, but both of them get inside the guiding catheter, and we took everything out. The patient was lucky. He had only a small dissection in the proximal LAD. We got intracoronary ultrasound to confirm there is no significant perforation or no significant dissection in the left main, but to make sure, we decide to cover everything from the ostium of the left main to the distal LAD stent, and we cover it with drug-eluting stent. 3.5 stent was deployed, provisional stenting with no complication. and the final IVUS was good. So the key message of this case, always to ensure adequate anticoagulation and align the guiding catheter during the retrieval of the stent. Check the stent and balloon integrity after retrieval. And if you face any difficulty, please call for a second operator or second hand and identify the lost stent or scaffold by fluoroscopy. Multi-wire technique is not encouraged because of low successful rate, and IFAS or intracoronary imaging is mandatory to confirm the stent opposition and to confirm the successful result. Thank you very much.